My name is Dr. Bizri. I'm a psychiatrist by training. I've also specialized in psycho-oncology, which is basically psychiatry or psychosocial oncology now it's called. And it's basically psychiatry for those patients that have had cancer at some point in their lives, whether they're patients that are undergoing treatment or cancer survivors. And why that is important is because it's been actually shown that the mental health experience, your cancer experience, having depression or anxiety will actually affect your clinical outcomes, so your cancer prognosis. There's a very high need globally for universal screening, and there's a consensus on that, for universal screening of patients with cancer. The problem is how we translate that to global settings. What we mean by that is these are countries like Lebanon, where I practice, that do have chemotherapy, they have advances in biological therapies, but what we're missing out on is the psychosocial component. And GlobalCan has actually predicted there'll be a 47% rise in cancer incidence by 2040. The largest burden of disease will actually be in the countries that are transitioning or low human development index countries by WHO, meaning low and middle income countries. And so the burden of disease will be higher in those countries. And what makes the burden of disease bigger and more urgent in these countries is that the social determinants of health play a bigger role. And so for any disease, there's an interplay between the psychological, physical, and social determinants of health. And that is more important in cancer care specifically. So when we talk about social determinants of health, we want to talk about access to care, you want to talk about employment, you want to talk about psychiatric well-being. And so the role of financial toxicity meaning the toll that having cancer will take on your finances. And so the role of financial toxicity, which is up to 25% in any country, even in high income countries, it's up to 25%. It's even bigger in those countries. And that's very important because it's directly associated. It's the biggest factor that is directly associated to non-compliance. So there are systemic healthcare service challenges. There are cultural patient-related challenges. There are funding and resource allocation challenges. And so I'll talk about maybe the system's healthcare challenges first. So every organization or institution you can think of calls for implementing a distress screening for unmet psychosocial needs. So there's a problem in that. The problem is when you're screening for depression, distress, anxiety, what have you, in a patient with cancer, you want to take that and implement it in their culture and use a culturally validated screening tool. And you can't just, it's not like chemotherapy, you take the drug and you take it and you apply it. It's not a regimen, it's not a protocol. So you have to develop these tools first and then translate them and have people that are trained that can implement them to be able to detect them. And so that needs a lot of research, which needs a lot of funding, which needs a lot of specialized healthcare workforce. There's also the cultural and patient-related challenges, meaning there's a lot of mental health stigma. That is different from having the cancer stigma itself. So there was a study in Lebanon actually that was very interesting that showed that 81% of oncologists that were surveyed would prefer addressing the family first before telling the patient about their diagnoses. And so you have that component. You also, because there's a stigma around cancer, like a global average, 1 out of 4 adults will have, that is without cancer, 1 out of 4 adults will have at some point a mental health disorder, but only 1 out of 10 of those, can you imagine, like only 1 out of 10 of those will actually seek help. So in many countries, mental health is not covered by insurances or by the government in many low and middle income countries. And so when you're talking about the financial toxicity to start with, patients will have difficulty really addressing psychosocial needs from a financial perspective, even if they do want to. And so what that means is you have a lot of non-compliance, non-adherence, you have a loss to follow up because the psychosocial component is not addressed. I think we have to think of it from a different perspective. When we talk about global health, it's no longer I think, well, funding not just for programs, but funding for research around what we can do that is culturally sensitive and specific. I think in global health, we've gone beyond the system where we just take something that works here in the US and, I don't know, equip it with money and send it out there. It doesn't work that way. So you have to really, I think when we talk about global health, we have to really think of a system that is capacity building in the sense that works with the structure, with the infrastructure that is already present. So we can't talk about really having more mental health providers. We have to talk about training primary healthcare providers to do that work, even if it's not done here. So in the US here, you have mid-tier providers, you have a lot of specialized, we have social workers, you have a social support system, you have financial coverage. So these are things that are not present elsewhere. And access to care. And I'll talk about two things. I think these are important when we think of low and middle income countries. One, we have to do the training at the level of community leaders, where you have to do it, primary healthcare providers. So I think the training is at a very basic level, and it has to be, you can't talk about more advanced care because because the infrastructures will take ages to get there. And two, I think, there's no way around it. We have to adopt telepsychiatry. Because of access challenges, commuting is a big problem for patients. Patients cannot afford these long transportations. And I think we have to adopt telepsychiatry in low and middle income countries. And we usually don't think of that because we tend to think, oh, you know what, these are low and middle income countries. We're not going to apply telepsychiatry there. But I think it's a system that is, well, you can't avoid it anymore. And I think it works perfectly, especially for psychiatry, where it's less interventional, less procedural intervention, I would say. So I think it lends itself to that platform very easily.